Hello again, it's Kimberly Hughes, your friendly neighborhood OB nurse, and today we're going to discuss pain management in labor. Okay, pain and the ability to deal with it is always up front in the mind of pregnant women. The stress and worry about what's coming can cause catecholamine responses, which we've talked about already. And one of the most important jobs of an OB nurse is to keep a woman in labor calm and as comfortable as possible. And we can accomplish this through both pharmacologic and non-pharmacologic means. Discomfort during labor is based on many things. There's a neurologic component. Contractions cause cervical dilation, and effacement and visceral pain stem from those cervical changes. Distension of the lower uterine segment and uterine ischemia are due to the decreased blood flow to the uterus during contractions. There's a diagram on page 373 that shows you exactly where women feel pain the most in the first stage of labor. Referred pain, or uterine pain that radiates around to the lower back or the legs, can also be felt. And in the second stage of labor, intense, sharp, burning pain is due to the stretching and possible tearing of the perineal tissue and pressure exerted on the bladder as well as the bowel. This pain is transmitted through the pudendal nerve, and we're going to talk about how to take care of that later on in the presentation. The diagram on page 338 shows you where women feel pain most in the second stage of labor, both in latent and the active phases. The third stage of labor is similar to the second stage, but less intense. Pain perception is based on the patient's idea of the meaning of pain, and the expression of pain, either verbal or nonverbal, usually stems from the primary social group. Expressions of pain can increase the patient's heart rate and blood pressure, and some patients may hyperventilate and require assistance with controlling their breathing. Nausea and vomiting may occur in the active phase, and uterine activity and placental perfusion may decrease. Some factors that influence pain are physiologic factors. Dysmenorrhea may have increased pain during labor. Maternal position during labor may increase or decrease pain. Endorphins, those natural opioids, are secreted by the pituitary gland and can help reduce pain. Culture has a huge impact on the care that a woman expects to receive during labor, and you can read more about that in chapter 18. But culture also has a lot to do with a woman's response to pain. For examples, there's several listed on page 393. Anxiety, as we have discussed, can increase pain. A vicious cycle occurs as the pain causes increased anxiety, and the increased anxiety causes increased pain, and it just keeps circling around and around, and we'll talk about that more in a minute. Previous experiences may also have an effect on pain and the patient's ability to cope. If a mom has a memory of herself or someone else going through some horrific experience, she may be more anxious than someone who did not have that memory or experience. Women who are addicted to drugs typically already have trouble coping, so they may require extra support. Substance abuse women also need to be monitored carefully in labor if you're giving pharmacologic pain relief to prevent drug interaction. If an opioid antagonist is required, we want to make sure that we know if a mom is addicted, because we can send her into immediate withdrawal if we give her this, which can hurt her and her baby. Childbirth preparation usually involves some sort of gate control theory method of pain relief, and we'll discuss that more, but the gate control theory is based on the idea that pain sensations travel along sensory pathways to the brain, but only a limited number can travel at one time, so that the gate will only let a few in at a time. So things like distraction can help block some of the transmission of some of the pain messages. Comfort, or lack thereof, can influence the response to pain. Providing comfort involves meeting the needs and desires of the patient. This provides for her feeling of comfort and support. Also helps to influence pain. A woman's perception of childbirth is affected by attitudes and behaviors of the caregiver. So an attentive, supportive caregiver will help with the perception of pain during labor and increase satisfaction with the labor experience. The environment may also influence the patient's ability to cope with pain. A quiet, safe environment with a few of her favorite things from home, like a comfy blanket or pillow, or some music, or a favorite pair of comfy socks, can help her feel more at ease. We kind of discussed this earlier. This is that anxiety or fear and tension and pain cycle. As fear increases, tension increases, which causes pain to increase, which causes fear to increase. As labor nurses, we have to find a way to break this cycle, or else the woman's pain will climb until it's out of control. And when this happens, the catecholamines will start circulating, which, as we've already discussed, will shunt blood away from the uterus and the fetus, which will deprive the fetus of oxygen. So knowledge about non-pharmacologic pain relief will come in quite handy on the labor and delivery unit. As I said in a previous presentation, even those moms who have an epidural or some sort of pharmacologic pain relief intervention can still benefit from these measures, because very few moms go all the way from start to finish without feeling anything. So whether you use a pharmacologic intervention or not, these are always helpful. Childbirth preparation is very beneficial because it provides mom with an idea of what to expect, and knowledge can help decrease anxiety. Relaxation is also important. As you recall, tension was part of that fear-pain cycle, and focusing on an object or breathing can help mom relax. We can also practice guided imagery, where you picture yourself on a warm beach with the sound of rolling waves in the background. At least that's very effective for me. I'm a beach person, but I guess mom can picture herself wherever. It might be mountains or the forest, or just wherever might be her living room, wherever she's most comfortable. She can also perform focused relaxation, where she works to relax specific parts of her body one at a time, starting from her head and working all the way down to her toes. Breathing exercises are also very helpful. Patterned breathing can be one of those distraction mechanisms I talked about earlier, and different patterns can be used depending on the stage of labor the patient is in. Most patterns start with a cleansing breath, and then they end with a cleansing breath. And moms may have trouble retaining control of her breathing as she enters that transitional phase, and she may need you to help guide her breathing. An example of patterned breathing is something like this. Breathe, 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 blow. Breathe, 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 blow. Watch for hyperventilation, and pant breathing can help at the end to help control the descent of the head. Counter pressure is also very effective, as is a light stroking touch on the abdomen or the lower back with breathing. Counter pressure on the sacral area with the fist or the heel of your hand can help during contractions. Music can also enhance relaxation and reduce stress. Other non-pharmacologic interventions include water therapy. That's buoyance, helps to relax and reduce pain. So bathing, showering, jet hydrotherapy, any of those is helpful. Transcutaneous electric nerve stimulation, or TENS, can also be safely used during labor 2 pairs of flat electrodes are placed on either side of the thoracic and sacral spine, and small electrical current passes through them to help relax the muscles. Acupressure is also helpful. It's pressure applied using the fingers and the thumbs to stimulate certain pressure points in the body. Heat and cold can also be used on these pressure points. Hot and cold application relieves muscle tension and increases hot application increases muscle relaxation and blood flow, and cold reduces inflammation and swelling, so it just depends on what makes the mom most comfortable. Touch and massage can also be helpful. It helps with relaxation to soothe sore muscles. Touch can be light or deep depending on the mom's preference. And oftentimes she won't know what she likes or doesn't like until you try it and she says, yes, that's great, or no, stop what you're doing. And you may have to try several of these interventions to figure out ones that work for her. Some may work initially, and then as she gets further along in the process, not work. So it's whatever is going to make mom the most comfortable and the most relaxed. And having an arsenal of these in our back pocket will help us to be able to pull out the right one that's going to work for her at this particular point in time. Here are a few others that are possible, but really require some specialized training on the part of the nurse. Hypnosis helps to increase relaxation and decrease fear and anxiety and perceptions of pain. Biofeedback is a technique where you learn to control your body by connecting sensors to specific parts of your body that give you feedback as to how you're doing with, say, your respiratory rate or your muscle tension. And this feedback helps you focus on those particular parts of your body to help, say, reduce the muscle tension, or doing that focused relaxation that we talked about earlier, which can help reduce pain. Aromatherapy has also been shown to be very beneficial. Scents like lavender and sage can promote relaxation, but you need to watch to make sure that anything that you're giving in the way of essential oils is safe in pregnancy. There's something called an intradermal water block, which is an injection of sterile water into specific locations on the lower back, which have been shown to reduce pain. This is usually the most effective in early labor. Now we're going to move on to pharmacologic pain management. And once again, I can't stress this enough, non-pharmacologic interventions should still be given along with pharmacologic interventions. Using both together really helps to optimize that pain relief. And everyone, as I said, can benefit from a decrease in anxiety and an increase in relaxation. So if your patient is expecting to use pharmacologic interventions, then encourage her to ask for whatever intervention or medicine that she plans on getting before her pain gets too high and her body starts producing those catecholamines we keep talking about. As you know, this impacts the fetus, but it can also prolong labor because, once again, blood is shunted away from the uterus, and the uterine muscles need that blood and oxygen in order to get into a good contraction pattern. So we really want to avoid this if at all possible. So here are some examples of some pharmacologic interventions. There's sedatives, which help relieve anxiety and induce sleep. So basically, mom is kind of out of it. Analgesia, what that pretty means is it's alleviating the sensation of pain by raising the threshold for pain perception. It's not blocking any nerve stimuli or anything like that. That's anesthesia. Anesthesia interrupts the nerve impulses to the brain. With general anesthesia, you also can have a sedative effect as patients lose consciousness. And there's also lots of side effects with both of these. Systemic analgesia, like opioids, has the goal to provide maximum pain relief, but but also minimizing the side effects to the mom and to the baby, as these medications do frequently cross the placenta. So see pages 392 and 394 in your textbook for more information about this. Okay, labor patients can also receive local anesthesia or regional anesthesia in particular areas, for example, the perineum. For those of you that have ever had stitches or ever had any sort of dental work, then you know what local anesthesia is. You numb a particular part of the body, and that feeling in that part of the body is taken away. So a perineal local block can be used if the doctor needs to either cut an episiotomy or sew up or suture up a tear in the perineum. Local nerve blocks also include what's called a pudendal nerve block. We talked about the pudendal nerve earlier. But medicine is injected around that nerve, and that nerve is what provides sensation to the perineum, so it helps with vaginal and perineal stretching. It may also help if the doctor thinks he's going to need to place forceps or a vacuum. Neither of these forms of anesthesia is going to help with contraction pain, though. This just has to do with the perineal area. And this is how a pudendal block is accomplished. The provider accesses the pudendal nerve through the vagina and injects medicine around it. A spinal or an epidural is a regional block that is achieved by anesthetizing the nerves that go to the lower half of the body. Some of the advantages is that pain is relieved without any sedative side effects, so the mom is completely awake and alert and can experience the birth of her baby without feeling all groggy and woozy. Some of the disadvantages is that the anesthesia also blocks the sympathetic nerve fibers in the lower half of the body, which help the body to maintain the patient's blood pressure. So without this feedback from these nerves, all the vessels in the lower half of the body relax, which can cause hypotension. And during episodes of significant hypotension, once again, blood is shunted away from the uterus and the rest of the non-vital organs and sent to the brain and the heart. So it's kind of like the body is thinking that, it's in shock. This can cause, obviously, impaired placental perfusion, and labor progress can also be slowed, and fetal descent can be slowed. This may have less to do with the actual medication and more to do with the immobility that comes along with an epidural. Women who aren't anesthetized and are in labor move around a lot. Women who do have an epidural move around significantly less, and this movement helps keep labor going. Additional disadvantages are infection at the injection site and ineffective breathing pattern, as agents within the epidural get absorbed into the circulation potentially, but this is not all that common. Neither is a headache, but it is possible, especially in the case of a spinal, because the needle actually goes all the way through and punctures the dura. And the spinal headache is caused by that cerebrospinal fluid leaking out of that hole. So some examples of contraindications of spinal or epidural are problems with blood coagulation or allergy to the medicine. So if that's the case, then the patient would not be a candidate for this form of pain relief. Nitrous oxide is also something that we can use. Some of you may have heard it called laughing gas. And in low concentrations, it's very useful to decrease pain, but you need to observe the mom for nausea, vomiting, drowsiness, dizziness. It's used a lot in Europe, and it's basically self-administered. So when mom feels like her pain is creeping up, she takes the nitrous oxide mask and holds it to her face, takes a few deep breaths, and then, as her pain threshold rises with the medicine, she brings the mask away and she continues on with her labor. General anesthesia is not used that much anymore, except in the cases of true emergency C-sections. The baby is not doing well, or mom is not doing well, and this pregnancy needs to be over right now, and we don't have time to wait to place a spinal. So it's very fast acting, but the drawback with that is, like with other systemic pain relief interventions, it crosses the placenta and goes to the baby. So there's a very small window of opportunity when mom feels the effects of the anesthesia, general anesthesia, and you can perform the C-section procedure or whatever you're doing before it crosses over and affects the baby. It's usually about 4 minutes. I've only seen this happen a couple of times. They put that mask on mom's face, she's out, and they start that clock, and the obstetric provider has to have that baby out within 4 minutes. It's actually kind of scary. I don't recommend it. The medicine administered with an epidural is usually injected into the epidural space between the 4th and 5th lumbar vertebrae to catch the nerves going down into the uterus. This is not an actual real space, it's more of a potential space, as the inside of the dura and the back side of the ligament right there, they're kind of right up against each other, but fluid and air can be injected, and when that happens, kind of push the dura out of the way, and a potential space is formed. If the needle goes all the way through and punctures the dura, then that's where we get what we call a spinal headache. Not very common, but it can happen. So here's a picture of cricoid cartilage, this is a picture of cricoid pressure. This is used in general anesthesia cases, which we've already kind of discussed is not all that common at all, but in the event that you do see it, you'll kind of know what's going on. So an anesthesia provider may ask a nurse to provide cricoid pressure in order to occlude the esophagus, which lies directly behind the trachea, so that no gastric contents come up and are potentially aspirated by the patient while the anesthesia provider is trying to intubate. Cricoid pressure is performed by pressing directly down on the cricoid cartilage, which is a firm ring that goes all the way around the trachea. So if I press on the front of it, it's going to press on the soft tissues of the esophagus that lie directly behind it, kind of blocking it so nothing can come up from the stomach. Not very common, may not see it, but if you do see it, you'll know what it is. So in order to provide adequate pain relief to a patient in labor, you must perform a thorough assessment to rule out any potential problems or contraindications. You also want to assess the patient's wishes and knowledge as it pertains to pain management. What does she want? And if she thinks she wants something, does she know all the ins and outs of it? You also want to determine her current pain level, so after you give your intervention or perform your intervention, you'll know if it worked. Did her pain level go down? You might have to obtain labs to rule out any coagulation problems and get a thorough history to determine if she's ever had any problems with anesthesia in the past or a history of narcotic abuse. Some nursing diagnoses that may go along with pharmacologic pain relief are, unfortunately, pain. Sometimes the interventions don't work or don't work well enough. Another is infection, as almost all the interventions will require a puncture of the skin somewhere, and potentially altered perfusion, because we kind of talked about hypotension could potentially be a result. The expected outcomes that we want to see with these interventions, hopefully, is a decrease in pain. So be sure to inquire about the patient's pain level after you've given the intervention time to work to see if it helped. So once you've determined potential nursing diagnoses and what you want your expected outcome to be, how are you going to make sure that you've achieved the outcome, or make sure that you achieve the outcome that you want? This is where your plan of care comes in. Your plan of care includes all of your nursing interventions that are going to help ensure that you achieve the best outcome for your patient. Your documentation of your plan of care should outline all of these items. If you plan to use non-pharmacologic interventions, then you should state what they are and what you did. If the patient wants a regional or general anesthesia, then an informed consent will need to be obtained. And preparation for these procedures, such as an IV bolus, need to be performed and documented. You also need to annotate what medication you give if you give an education if you give a medication like an opioid. You want to say what you gave as well as the time you gave it. Safe medication administration also includes considering the route as well as the size of the patient. Bigger patients may require more medicine. Any potential allergies of the patient and any possible adverse events that may go along with the medication. So in summary, pain management is important to help ensure optimal birth outcomes. Uncontrolled pain can lead to problems for the mom and the baby. Pharmacologic and non-pharmacologic interventions can be used together and should be. All pharmacologic interventions have side effects. All of them have some sort of side effect. And some are contraindicated altogether depending on your patient. So you need to collect a thorough history to ensure that the intervention you're getting ready to give is safe for them. Because safety is paramount. We want to decrease mom's pain, but we also want to ensure that she has a safe birth experience. Thank you for your attention.